So now our fifth lecture, it's the last lecture in topic of sterilization and surgical infection. So what is a surgical infection? It's an invasion of microorganisms to the healthy tissue producing inflammatory reaction. Pathogenesis and bacteriology. Microorganisms usually prevented from causing infection in tissues by intact epithelial surface, mainly the skin. Protective mechanism includes chemicals, it's a low pH of gastric juice. Humoral, it's the antibodies, complements, and the spores. Cellular, it's a phagocyte cells, macrophages, polymorphia nucleic cells, and killer lymphocytes. So host response can be weakened by several factors. Of course, it's metabolic features like malnutrition, including obesity, diabetes, uremia, and jaundice. So it's all chronic disease which has the metabolic features. Disseminated disease like cancer and acquired immune deficiency syndrome, ADS. Iatrogenic, it's radiotherapy, chemotherapy, and steroids. So after using of this method, also we can see patient with surgical infections. The chance of developing infection is also determined by pathogenicity of the organism present and the size of bacterial inoculum, derivatives tissues, excessive dead space, or hematoma. All the results of poor surgical technique increases the chance of infection. These pictures on the center, you can see hematoma after some type of operation. It's an amputation of the lower extremity of lower extremities. Diagnose history. It's about history. We ask about history when onset this surgical infection. Second, it's a clinical examination. Clinical features of acute inflammation we talk about in our previous lectures. It's 5 features: color is or heat, rubor or redness, dolor it's pain, tumor it's swelling, and functional leisure it's a loss or impairment of function. Third, it's a laboratory investigation and radiology imaging. An infection may resolve spontaneously, or it may destruct tissues, abscess which may rupture spontaneously, sinus or fistula formation, spreading infection, death of tissue. Another, it's a gangrene with its systemic effect. Bacteremia, septicemia, septic shock, multi-organ failure, disseminated intravascular coagulopathy, and unfortunately death. So at this picture you can see this complication of surgical infection. Treatment, first it's a source control, it's a draining an abscess. Yes, we had some rule. If we see pus, we should drain this pus. Resecting of debriding dead tissue, diverting bowel, relieving obstruction, and closing a perforation. Antibiotic treatment of a surgical infection without this mechanical solution will not resolve the infection. Postoperative wound infection, or another name, it's a surgical site infection, SSI. It's a wound infection, invasion of organisms through tissue falling, breakdown of a local or systemic host defense. SSI are an infection of tissues, organs, or spaces exposed by surgeons during performance of an invasive procedure. So at this picture you can see after suturing we have some hyperemia. So it's features of surgical site infection. Surgical site infection, infection of surgical wounds. It can be superficial, the upper, and deep surgical site infection. It's the infection in the deeper musculofacial layer, or organ space infections. Major surgical skin site infection discharge significant quantities of pus, either spontaneously or need surgical drainage, plus local signs of infection patient, plus systemic signs, tachycardia, pyrexia, and raise of the white blood cells count. Minor surgical site infection may discharge pus or infected serous fluid without systemic signs. Treatment of surgical site infections minor may resolve spontaneously by frequent dressing change, may require drainage, and major drainage of pus may require debridement plus using of systemic antibiotic. So for systemic antibiotic, for us, of course, it's nowadays using of cephalosporin, yes, second generation of cephalosporin. Cellulitis and lymphanginitis is non-suppurative invasive infection of tissue with poor localization plus cardinal signs of inflammation. It's spreading infection by the major host. It's a beta hemolytic streptococci and staphylococcus and perfringens, Clostridium perfringens. Tissue destruction, gangrene, and ulcer may follow, which are caused by release of proteose and a low spread of infection. Clinical features: well demarcated area. Yeah, you can see this example. It's the lower extremities with cellulitis. Hot, red tenderness, swelling, and impairment of function. Malaise, chills, fever, rigors, and raised white cell count. So it's a clinical feature. If not rapidly treated, it can progress to lymphangitis and lymphadenitis. Localized area of skin necrosis may occur. Yeah, at this picture you can see this complication like skin necrosis after cellulitis. Predisposing factors include lymphedema, venous stasis, diabetes mellitus, and surgical wound. Management: it's a rest and elevation of affected limb. Antibiotics using, or it can be orally or intravenous, using by benzylpenicillin and flucloxacillin. And lymphangitis is part of the similar process and present as painful red streaks in affected lymphangitis. It is associated with painful lymph node groups in the related drainage area. So at these pictures you can see all of these predisposing factors. For us, of course, very important, patients control count of glucose patient with diabetes mellitus. So we next lesson lecture we will talk another surgical infection. Thank you for attention.